We have our next speaker, Dr. Rohan Mehra, using FLACS for astigmatism correction.
Very good morning to everyone. Thank you so much, Dr. Himanshu, for including me in this course. So the first question when it comes to treating astigmatism is actually to treat it or not to treat it. Because we know that in a few cases, in a few situations, astigmatism can actually be used to our own advantage when it comes to post-operative outcomes. Size and location is the most important factor. We know that with age, against the rule, astigmatism keeps increasing. So we need to take that into consideration when we look at long-term results of our surgery. So 3 basic ways in which we can correct astigmatism: toric, LRIs, and arcuates. We know that FLACS has improved refractive cataract surgery outcomes over time. There are different FLACS platforms that are present: the LensX, Catalyst, LensR, and the Zemer. All of these have the inbuilt softwares in which we can use these softwares to take care of astigmatism in different modalities. So the image guiding assistance, as we know, there are the corneal incisions. I've marked them out for you so that it becomes much easier for us to see. Then you have the nuclear fragmentation, the capsular X's, the arcuate incisions are the ones there. So image guiding surgical planning with 3D visualization is, of course, an advantage. Real-time corneal thickness we get in this. We know the exact percentage depth that we have to go to, the length and position of the incision, 3D visualization of incision placement, predictable incisions, the width, tunnel length, titrable incisions, adjustable during the surgery procedure, and as Dr. Tityal had mentioned in his talk, adjustable post-operatively at the slit lamp also. So you can, we say that, you know, life gives you one chance, cataract surgery gives you one chance, but here actually you can take another chance later on as well. So this is basic planning on the LensX platform. Once you have chosen, you have all these parameters to choose from, and every single particular patient, you can go ahead and you can choose what your incision location is going to be, what your depth is going to be, what is the exact size you're going for. And there are various nomograms in which you can actually take care of it. So these are the most used ones: the Donenfield's monogram and the Solomon's laser arcuate monograms. These have been modified now, and there is work in progress for further modifications of these nomograms, which are used and can be used for astigmatism correction in FLACS. Then you have the Weinstock Panchal, that's also a limber relaxing incision nomogram that is followed. So here is a case, this is actually a posterior polar cataract, and in this case as well, you can see there are arcuates that are going to be made on the side after the planning is done initially, and you see you leave out a decent amount at the back because it is a posterior polar cataract. Then once the laser is fired, you will be able to see that even in these cases, predictably, one can go ahead and make arcuates and make sure that the patient gets the perfect vision that one desires to give to the patient. You see there. Now, sealing these arcuates at the end also, this becomes a challenge, like how much of fluid is to be put, how much of pressure is to be put, all these factors, and how well this gets sealed. Because we are used to sealing the incisions that are limbal, that are right at the limbus. This is something different. This is on the cornea. So sealing them, there is a slight amount of learning curve in this. So here you see, this is a beautiful video of a 3D. You see from the outside how you can actually open up that incision beautifully in the eye, and it is guided, it is neat, it is clean, and it gives us the desired result that we want. And these are the post-operative outcomes you can see in the image in the top right. There is a marking for the toric also, if you see, but there are those big arcuate incisions. So in our experience, as sir said, that up to 1 diopter, actually you can avoid a toric if you do use these machines that are there in our armamentarium, and they will take care of the astigmatism that is there for the patient. Of course, we have to consider the with the rule and against the rule. So these are the vector analysis of refractive and keratometric changes that have been there. So you see the mean, the minimum and the maximum. And in all these cases, you can see that up to 1.21, 1.20, 1.2, 1.16. So consistently, this is the value that we are getting that can easily be corrected without a toric by using FLACS. So in the end, I would say that we need to evolve. Everything has to evolve or it perishes, and it is evolving with the ever-changing nomograms that are coming in. Thank you.
Thank you, Rohan. What is the largest amount of astigmatism that you have done? And have you ever done it after a couple of months again?
No, sir, not after a couple of months, but yes, about 15 days post, and it was about 1.5 diopters.
So it definitely has a place in time. LRIs were not very great with a diamond knife. We have done that in the past, all the various nomograms. But with the various machines that we have now, the Callisto, the Varion, makes life a lot more easier to plan in majority of cases. Again, in the interest of time, thanks for sharing your views on